Thessaloniki, who has a great experience also from Germany. And we are really keen on listening to you. Vasilis.
Hello, hello all. Hello to the audience and to the auditorium. Thank you very much for the invitation. So I will speak about the extracorporeal circulation in totally endoscopic cardiac surgery procedures. Some historical data first. The idea came in the early 90s, and the first attempt made in Stanford in 1995, and they called that as port access. And we see now they use the femoral arteries for connection to the cardiopulmonary bypass and to give also the cardioplegia. And the aortic clamp was an endoaortic balloon. So in 3 different cities, 3 different surgeons persist with this idea, with their methods, and after some years, adapted many surgeons, one of those 3 approaches, and leading on this paper in 2010. And coming today, another team, another group of surgeons introduce us this statement for those who want to start an endoscopic cardiac surgery program. So our devices in our center is from Storz, the 4K monitor and the recording system, 4K camera, and the robotic arm from Storz. Our cardiac surgery spectrum includes almost the whole spectrum of cardiac surgery. Most of the times the incision is a perioalveolar incision. Our heart-lung machine is from Spectrum, and includes the monitoring system, which is crucial nowadays. Includes an 8-inch pump, 2 4-inch pump, and 3 6-inch pump. 4-inch pumps for suction and delivery with the cardioplegia. Also includes the ventilator system, which has also a vacuum assist device, which is important in the endoscopic cases. So our occlusion protocol method, actually, which we are performed in our center, is based on a study from Tamari and called hemodynamic occlusion or non-occlusive method. This method can reduce the hemolysis, which is produced from the pump in a degree less or in the same degree as a centrifugal pump. The initiation method we are using is that we are going on full bypass and cover the 100% of the cardiac index on at least 90 seconds. This protocol is based in a study from Germany, which the results showed that the oxygenation of both hemispheres are better when we are going slowly on full flow than fast, like 30 seconds, for example. These results confirmed also from us on our single center study last year. Of course, we are using a goal-directed perfusion. This protocol is well described in many studies and included also in the last guidelines of cardiovascular perfusion. And it's very important to monitoring the whole parameters like DO2, VCO2, VO2, but the big difference between the endoscopic cases and the full sternotomy cases, it's because we are fluiding carbon dioxide in the field. The carbon dioxide goes into the reservoir, so the carbon dioxide make all the parameters faulty, but one parameter stays reliable, and this is the delivery. So delivery oxygen, the DO2 is always a parameter that you can check and you can trust. So for the cannulation, we use the femoral artery and the axillary artery. And for the venous cannulation, we use the femoral vein and the internal jugular vein. The method can be surgical incision or percutaneous method. And always we confirm the method with the transesophageal echocardiography. The cannulas we are using is either the Medtronic EOPA 18 or 16 French or the Edwards Flex cannula. And for the venous cannulation, we use 21 French or 25 French multi-stage cannula. Because of the small size of the cannula, we need to use a negative pressure, so the venous assist device is important in every case. Our cardioplegia is the custodial cardioplegia. We give 20 milliliter per kilogram as initial dose, either in the aortic root or selective in the ostias. This can be in 6 to 8 minutes for a nice equilibrium. And after that, we wash the whole volume with the use of the hemofilter. So now I have prepared some videos, some incidents in order to realize how important it is to react fast and to stay focused on the screen the whole time. So here we have a cannula dislocation, and we have the negative pressure in a high amount, so the right atrium is not empty enough. The negative pressure is going higher in order to empty the right atrium, and we see that the cannula now is in a good position, and we realize that the negative pressure was so high, and now we need to normalize the negative pressure in order to avoid this banging of the superior vena cava. Here we have an obese patient. It's difficult to do endoscopic case to obese patient. You don't have a full empty right atrium. So what to do? You can reduce the temperature, and if you have a good hemoglobin, you can reduce flow, easily go down to 1.8 cardiac index if you have 32 degrees of Celsius, and always check the delivery of the oxygenation. Here we repair the mitral valve. We are looking that it's not empty enough in the field. There is a blood. That is because of the suction in the pulmonary vent is collapsed into the pulmonary artery, and now is sucked very nice. The surgeon needs only to suck the field to see better. Here, a splatter on the camera can be a big mess. You cannot see nothing at all. What you can do, maybe increase the pulmonary suction, maybe lower the flow a little bit. You see nothing at all until the surgeon cleans the camera. This is a big mess, actually. Now we see that the right atrium was full, the pulmonary vein wasn't sucked enough, and now everything it's okay. So it's very crucial to see the whole time the camera and the monitor. In this case, we give cardioplegia. A big amount of volume goes inside the heart. I have increased the negative pressure. Maybe I have reduced also a bit the flow in order the right atrium and the whole heart stays empty. And then the cardioplegia will stop, and we will suck the root vent. You will see in a minute. Now we suck on the vent. Because of the high negative pressure, now we'll start the superior vena cava to pumping, because now the volume inside the heart is empty. So to avoid this, we need again to normalize our pump in the normal flow and to decrease the negative pressure. Here is a tricuspid valve. You see there is a nice red blood pool. We cannot suck air, and the surgeon can see very nice what he has to do. But it's not always like this. It's not always that you can find balance in these cases. You see that in this case, it's difficult, but don't panic. There is a solution. There is a solution for everything. So you need to communicate with the surgeon to put suction in the field and use it. And use this suction as an assistant to find the balance between not to suck air and the surgeon to see. Now he can work nicely and could be also happy. So we spoke about the carbon dioxide in the field. It's crucial to give to fluid carbon dioxide because of to reduce the intracardial air. But in cases that the right atrium is open, you need to go very high in the ventilator system to eliminate the carbon dioxide from the oxygenator. Thank you very much.
Thank you very much, and congratulations for this analysis. I do think that getting good communication and expertise from the perfusionist is very helpful, particularly when you're using the blood-air interface as you do on your right side surgery, which you showed very elegantly. Would Dimitris like to make a comment, please?
Vasilis, thank you for excellent presentation. You are highlighted with excellent way some differences between the traditional opening surgery and the minimal invasive. Also, you have mentioned how important is the management of the arterial and vein, because especially at the minimal invasive, you need to have a big experience like a perfusionist, many miles on the machine, the heart-like machine, and you have to face some very important differences, especially when you have to have approach of femoral arterial and vein, and you have to manage very accurately and not only accurately, but you have to manage the negative pressure if your target is to help the surgeons and to create special clear field, surgical field, and the negative pressure is also a weapon, and sometimes also with a bad or a good results. And also another very important point that you have make a mention is the communication between the perfusionist and the surgical team. If you want to have the best results, as mentioned before Professor Kofidis, you must have excellent communication between perfusionist, a surgical, and the surgeon. In a recent article, I have read that the perfusionist is the secret gem in the operation room. Could have also the role of the communication between surgeons, anesthesiologists, and nurses. Thank you, Vasileios.
Thank you very much for the comment.
Thank you very much, Dimitrios. There's a question from the audience about the size of the venous line. I think, of course, your views are very valid, but it's not just a matter of size, but the kind of venous return you use. If you use jugular, do you want to comment on that, Dimitrios?
You have also to compare what you want, but what the patients and the anatomy of the patients give you the opportunity to use. It's not so simple, and I think it's not a rule. This is a point of that we said you must have a lot of miles on machine, a big experience, and only on that case you can help the surgeons. The size is not only a matter of bibliography. You have to adjust to the patient.
Thank you very much. Yes, please. Some more comments from our colleague.
I want to thank also Vasileios for his excellent presentation. And from my point of view and my experience right now on minimal invasive, I have to say that we all have to work as a team. The experience of the surgeon, of course, is a key play for the whole team, but also the machines that we are using. The spectrum give us the opportunity to go and help the surgeon in a different way, because we can use all the other values like DO2, VCO2, and to see the perfusion in that way. In our hospital, we use the Livanova, the Stockert S5, and now we are using also the Big Apta and the card. So we are using Gold Direct Perfusion. And that is the introduction for our next webinar and the last for this year, which is going to be focused on Gold Direct Perfusion. Thank you, Vasileios. Thank you,
Thank
Dimitri.
you very much. Thank you.
Thank you very much, too. I think just to make a comment, too, on all this, what we really need around the world, but in Greece a bit more, is a lot of real data with very honest information, without judging, without trying to pinpoint one to the other, so that we can improve our knowledge. You see, there's so many techniques and so many instruments and weapons in our hands as we're in the army, but we really need to learn which one is useful in each situation. And of course, insights and our general anecdotal beliefs are important, but I'm sure we can create data if what Professor Kofidis said, we forget about egoism in all this, and we just try to create enough data so that we can advance. It's very impressive how much better we become as we try and we improve. So I think this is a key message that comes from the communication, as Dimitri says, too. I do like to shout sometimes, don't I? So yes, you have a really central role in getting the good communication, and it's very important to have visual contact too. This was very nice, as you showed. We spent about a year with our senior anesthetist, not Dr. Falara, trying to convince them that the monitor should not be under the anesthetic sheet, as you said, it should be above, so that we can both share the picture. So thank you very much. This was, yes, please, comment.
For Vasileios, maybe have you ever faced, are you using
I'm not sure he can hear you.
Hello, this is Angelina Chorba from Henry Dinan Hospital. Hi, Vasilis, how are you? I have a question. Do you apply any vacuum, and if you ever had any trouble using vacuum for
vacuum,
venous return?
yes. So in every case, in 90%, we use the vacuum assist device. I think it's almost 100%. We cannot perform endoscopic case without the vacuum because the right atrium remains full of blood because of the size of the venous cannula. They are small. We apply sometimes minus 70 millimeter of Hg negative pressure. It's a bit high, but you cannot work without it. And as my experience also in Germany, these values of negative pressure is high. Or for any problems, no, I didn't see problems. Sometimes we see hemolysis, maybe because of the time of the cardiopulmonary bypass, but I didn't do any study about the hemolysis that can react against the negative pressure.
Okay. My experience, it was actually many years ago, applying vacuum on my venous side, venous cannula, and the cannula was bented, kinked on the table, and then fortunately it was right before going on bypass, and the whole system was emptied, sucked, So that was a little bit. This experience was a little bit weird. And fortunately, it was right before going on bypass, so I had time to recirculate and remove all the air. So I was wondering if you ever had to experience such a case.
So in the bibliography, you can find incidents like if you apply a negative pressure before the bypass, then you have a closed system, and the oxygenator can be sucked into the reservoir. So you have an opposite way of the water. But this happens if you have a closed system, and sometimes the perfusionist apply negative pressure before going on bypass. So this is not a good idea. A good idea is to go slightly into the bypass, maybe 20%, and then apply negative pressure to avoid this incident.
So you go first on bypass for a few minutes, and then you apply the negative pressure.
I'm going on bypass maybe 1 liter, and then
later you apply the vacuum.
Yes.
Okay. All right. Thank you.
Thank you.
I had just a comment on the pressure you go, or the negative pressure of 75. Don't hesitate to insert another cannula, a jugular cannula. 14, for example, French in larger patients can avoid this and still work with 35, 40 max of negative pressure. Thank you.
Yes, indeed. In some centers, they are cannulate also the jugular vein, and they have a jugular vein and femoral vein cannulated. Unfortunately, in our center, we don't do that, except in a few cases like AVD or ASD.
So as we conclude today's sessions, I would like to emphasize one key takeaway. Success in thoracoscopic cardiac surgery is never the work of a single pair of hands. It's the result of coordination between a surgeon, anesthesiologist, perfusionists, and not forget nursing staff and the entire operating room staff. So thank you all for participating in our session. Thanks a lot to the speakers for their excellent presentations and valuable insights. We look forward to seeing you at our next session in a month from now, 28th of May.
Okay, on the 28th of May, the last Wednesday of May, we are waiting for you to watch our session. It's going to be about goal direct perfusion, as Victoria said. Thank you and have a good night.